Good evening to all of you. Once again, on behalf of Translumina, I am Ehsan, welcoming you all to this one of the finest platform we have curated and created in the last few years. What we call as OPNNC colloquium. This has been brought together with the help of this is medical and Translumina to you, and it's a great opportunity where we get the full chance of getting exposed to international and national speakers coming in from different part of the country. But before we get into the discussions today evening, we have a great panel of speakers, chair, moderators who will really contribute to make this platform a great exchange of learning and sharing between all of you. So, but before that, a very sneak peek view of what does Translamina stand for, just to show you how our journey had been throughout these years. We started a humble beginning in 2010. Within last more than a decade, we are a company which has really traveled a long distance and trying to create a lot of products which will help you to collaborate. And to see that how do you impact the outcome of patients right from the one spectrum of the PCI. If you talk about vascular access, we have every product for access. Then it comes of imaging. We have acquired an imaging company. When you talk about lesion preparation, we have IVL and OPN. When you talk about lesion treatment, we have DEG and a drug-eluting stent. If you have talk about evolution, we have come with options physiology. Means everything right from or access to closure. Except for the closure, we have everything that basically we can collaborate to see that a patient's outcome is improved. Having said that, we are a company. We are the only company with having a great technological stand. Now, recently, we also acquired a company called BlueMed, which help us by virtue of that to get one of the finest drug-eluting balloon ever we can have in the world today. So we have acquired this product. We have also acquired a company called 𝐂𝐨𝐥𝐿, which is increasing our German presence. We have one of the finest stands, what we call as Yukon Choice and Vivo SR, which is in the category of polymer-based and a polymer-free stent, which is helping patients. I think all in all, we have really a great source of product which help us to see that we make life better for your patients. Now, what we will be doing, we really want to hear from you. But before we get into the discussion, I have the privilege of introducing the moderator of the evening, who in turn will introduce all the speaker chairs of the evening to start the talk. I have a great privilege of introducing Dr. Abhisheka Tripathi, sir. He's a very senior intervention cardiologist at Zydus Hospital, Ahmedabad. He has really made a great contribution towards the field of intervention cardiology. I think today he will take us to an introduction of all the speaker and chair, and will be moderating the session this evening for all of us. So over to you, Abhisheka sir, to introduce the panel, and then let's go ahead with the first speaker. Maybe we can have Dr. Rajiv Lochan sir. I think he is ready with that. And then we have Dr. Ashok sir also. And then we have Dr. Mova Srinivas. We have already have, and Dr. Kapar. I think Dr. Kapardi sir has come, so we can have him as the first speaker because he is the first one to go. So over to you, Abhishek sir.
Thank you, Ehsan bhai, and thank you, Translumina, for arranging this OPNNC colloquium. And as we know now, with increasing penetration of intervention cardiology, doing more and more complex cases, this is a calcium which bothers us always, which has always bothered us. But thanks definitely to Translumina, which has brought certain technology like in the form of IVL, in the form of OPNNC. Now they're coming with IVUS and all these things. So that has actually made our life easy while managing these patients with a calcified and ugly lesion. So in today's OPNNC colloquium, I welcome all. And today with us we have chairperson Dr. Aftab Khan from Kolkata, Dr. Sharat Chandra from Lucknow, and Dr. Girish Navsundi from Bangalore. Our international faculty today is Mr. Matthias Bassard, and he'll be joining us shortly from Switzerland. Our case presenters, international faculties, they include Dr. PLN Kapardi sir from Hyderabad, Dr. RL Bhanja from Chhattisgarh, Dr. Parminder S. Mangera from Punjab, Dr. Ashok Kumar from Chennai, Dr. Praveen Shetty from Bangalore, Dr. Tejveer Brewal from Haryana. And we have expert panelists Dr. Devopriya Mondal from Kolkata, and Dr. Anupam Bhambani from Patna. So I opened the session for having a very deliberate discussion over calcified lesion, how to manage, more so evolving how we all have used OP&NC and what is our personal experience regarding OP&NC and how it has made our life easy. As I have been told, our international faculty is running slightly late. So we can start with Dr. Kapardi
We
sir is
have the
there?
international faculty now.
Okay,
Sir, he
he's
has
already there.
joined. My Dr. Matthews Basad.
Welcome, Dr. Matthias Bassard. So we can
Good
start our
afternoon.
session directly with demystifying the concept of crack and coat. Over to you, Dr. Matthias.
Thank you very much for the kind invitation. I was really surprised and I apologize for being late. I had some technical issues. Let me just 1 second. I'm going to share my presentation. Um, can you hear me well?
Yes, sir.
Okay, perfect. Okay, so I was asked to talk a little bit about the role of the high pressure and balloon OPN in DCB PCI, as I understood the title right, and I actually liked the title, which was telling us to demystify the concept of crack and coat, something which is daily practice here at our hospital in Lucerne, Switzerland. So I'm very enthusiastic about the topic, and I guess the majority, you can see my slides, the majority of you know my boss very well, Florian Sützli. He's unable to give that talk today, and I was lucky to adopt him from him, and I hope that I can step into his big footsteps and provide you some important insights about our approach, how we tackle everyday lesions, all-comer lesions, complex lesions, and treat them with the crack and coat approach or DCB and leave nothing behind by doing so. I'm sure that some of you would tell me now or believe or think that there's no longer room for talking about DCBs because the dream is over. We now have firm evidence which tells us that drug-eluting stents should remain the standard of treatment for coronary lesions following the recent study from China, 𝐂𝐥𝐥𝐥1 trial, which indicated that drug-eluting stents do really well if you don't pay attention and just throw them in, but drug-coated balloons were not non-inferior to drug-eluting stents up to 2 years follow-up. But when you look at that trial rightly and ask yourself, what does it tell us? It actually tells us that, as I said at the beginning, drug-eluting stents work really well in regular lesions, also with really minimal lesion preparation. And on the other hand, drug-coated balloons can be safely used with a low rate of target lesion failure if you don't prep the bed very well. So that's how I understood this trial. And also, I think the books aren't closed yet. It's just the beginning of a series of large randomized trials which come in the near future, which tell us more about the potential of drug-coated balloons. And on the other hand, we just recently had the introduction of the updated ESC revascularization guidelines, which also were kind of surprising for us. And a panel of non-PCI operators advised us to no longer use drug-coated balloons for treatment of instant restenosis. Again, I think, or we think, that's bullshit, and we can't extrapolate very old data to contemporary practice. And therefore, we should talk a little bit more about the role of DCB-based PCI. So, as I said, and to the majority of us, it's apparent that drug-eluting stents are not the final end of PCI, because we need to be aware that at least 10% of all our patients who have a drug-eluting or a contemporary metallic stent implanted will have some sort of stent-related problem down the road. And that's relatively recent trial or registry data, which indicated that on average we can expect an ISR rate of up to 10% after 5 years in the majority of our patients. And this risk is even higher among patients who have fibrocalcific or complex coronary lesions. And what can we do about that? Pills, laser, brachytherapy, or whatever, just tackle the in-stent restenosis. I personally believe that's not the solution. I think we should actually avoid, whenever possible, placing a stent or a metallic stent in the first place and look for alternatives. And that's what we're going to talk about, how to properly prep the bed or the lesion to ultimately just finalize it with a contemporary drug-coated balloon. And the idea should, for every interventionalist, be, whenever possible, leave nothing behind. We should actually use metallic or avoid metallic stents wherever they could fail. And this includes especially calcified and complex lesions, as I just mentioned. And here's a nice slide, a very old meta-analysis by Adnan Castrati, who indicated or who told us which lesions are prone to fail. And over the last 20 years, things haven't changed much. Even though we have better drug-eluting stents, we have a few more tools to prep the lesion, but still in-stent restenosis is a nuisance, especially in those 5 types of lesions, including CTOs, highly calcified lesions, long lesions, diabetic lesions, and bifurcations. By using DCBs, we have the potential of leave the vessel uncaged and to aim for late lumen gain, prevent unnecessary stenting, prevent by doing so ISR or the onion skin phenomenon whenever we have multiple layers. And a topic which is getting more and more attention is that we can prevent dual antiplatelet therapy, especially since our patients, wherever you are on the planet, are getting older, and therefore the bleeding risk or the risk, the burden of comorbidities is also increasing. Therefore, the number of patients which are prone for bleeding complications is steadily growing. And as I said down here, whenever you don't place a stent, you can't have a stent thrombosis. So, how should we do DCB-based PCI best? Everyone's an expert, my way or no way. And there's actually not much guidance out there. And there's still a lot of debate how and when we should use DCBs at all, and which drug, etc. But the majority of doctors aren't talking their elephant or aren't discussing the elephant in the room. And that's actually not, it's not so much about which drug or which balloon. It's more about how to prep the lesion adequately to ultimately use a drug-coated balloon. And what we want to use or do by using drug-coated balloons in our patients, we want to add value for our patients and improve long-term outcomes. Here's a very straightforward slide or figure which tells you how not to use DCBs. And there's still that belief that by using DCBs, you could actually use DCB for direct treatment of the lesion. But in reality, that's not feasible or not going to work because, as you're well aware, the majority of DCBs which are available are super semi-compliant balloons, and you will easily end up with dissections. There's some guidance from expert or so-called experts in the field who tell you how you should prep the lesion before you use a DCB, and they tell you that you should actually predilate the lesion. In the majority of cases, you can use a semi-compliant balloon, or if it's a bit more calcified, might use a modified balloon or a non-compliant balloon, and use a 1-to-1 sizing, balloon to vessel ratio in terms of sizing. For us, or at least for myself, that's bullshit. Semi-compliant balloons for lesion preparation, that time is over. And because everyone's aware, by doing so, you will end up having a duck boning effect, and you will destroy the vessel architecture. You will leave uncontrollable dissections behind, and it's actually almost impossible to adequately size balloons, basically only just based on angiographic information. And by doing so, by using a one-to-one sizing approach, you will overstretch the vessel, which will also destroy the architecture of the vessel. Here, a very nice illustration how you should actually predilate a lesion, just simplified. That's a very calcified lesion here, LAD on the left. Here we do in the middle part, you can see PCI with a regular balloon up to 20 atmospheres. The balloon is not doing anything at all to the lesion, but it ultimately got cracked with an OPN at 50 atmospheres. And here on the right hand, you can see the non-compliant compared to the semi-compliant balloon. And I think, to me, that's very convincing. Therefore, we almost completely abandoned using semi-compliant balloons for lesion preparation, at least at our site. We still use them, but only to correct malapposition and restore flow in very thrombotic lesions. The majority of those are MI patients. So what you don't want to have is illustrated in that picture on the right side. Here's a calcified RCA. The operator who fixed it used the semi-compliant balloon, and you can see what happened. Really nasty spiral dissection. So message is clear. Don't tackle or don't go after calcified lesions with large semi-compliant balloons, because you will end up with complications or troubles. So then the question comes up, which device should we use to tackle everyday calcified lesions once we want to treat them with drug-coated balloons? And everyone's an expert. We now have a portfolio of multiple tools which can help us to address calcifications, but it's uncertain which one we should use. And if you're influenced by the industry, or if you're really close to the Americans, you might aim for the device from J&J, which will have a very fancy generator attached to it, and which usually creates some noise. But it takes a lot of time, and it's also very expensive, at least where I'm working at. And then on the other hand, you have a series of atherectomy devices, including also laser atherectomy, which I have never used. But in many cases, those devices are just an overkill. And again, it's very time consuming. By using this device here, which I just highlighted, the high pressure NC balloon, or OPN called, you can actually easily go after the crack and coat approach. And it's not just safe, it's also very effective. And I'm going to show you a few convincing cases over the next few minutes. Okay, so time will be limited here in my talk. We have some basic principles how we tackle everyday lesions if we are aiming for DCB therapy. First and foremost, vigorous lesion preparation is key, and I'm well aware that using DCBs is more cost intensive than just throwing a stent in following ugly lesion preparation with semi-compliant balloons. And also, I advocate again here, use intravascular imaging. By doing so, you not just generate costs, you save a lot of time and money down the road, because you know upfront what you're dealing with. And whenever you aim for DCB-based PCI, use dedicated tools for lesion preparation. Every once in a while, you first need to use atherectomy to even cross the lesion. Then we strongly advise our doctors here, or our interventional fellows, as well as our other peers, to use true NC balloons. And the one which stands out here again, it's the OPN. Whenever you are facing fibrotic tissue, we might add a modified balloon, a cutting balloon, or scoring balloon. And on the other hand, when we have ugly dissections, we might also go back and use a cutting balloon to tackle those dissections. But I'm going to talk a bit more about that. Again, we strictly avoid semi-compliant balloons for lesion preparation. The aim is to crack the calcium. We are doing it the way that we downsize the diameter of the balloon and upsize the pressure, and we're often not afraid of dissections. So why are we strongly convinced that the OPN represents one of the most powerful tools in DCB-based PCI? And here are some reasons. It has a low entry tip. It's easily deployable. You can actually save a lot of time by using it. You don't have to install a generator. And actually, it has a very uniform compliant chart, and a very predictable inflation profile. And again, it has proven safety and efficacy. As I would call it, it's kind of a Swiss Army knife in your cath lab. It's easy and it bails you out in most of the cases. Some would still say, I'm not convinced. What is he talking about? Now I'm going to show you how to tackle those cases. I truly apologize. I had prepped a presentation on a different computer because for some technical issues, I wasn't able to use my hospital computer to present a case. So I will have to skip that, and I will fast forward, jump to the next case. So that's a regular case. Some of you might have already seen it in the past. That we like to show it because it's a really convincing case to us. It was one of our first TCB cases, heavily calcified cases, which we treated with a purely TCB case. It was a non-STEMI patient who was unwilling to take any medication on the long run, so no brainer. There was no reason, no way we were going to place a drug-eluting stent in that patient. On OCT, you can appreciate heavily calcified. That's how we fixed it. Initially, we used the cutting balloon, but then we ultimately used an NC balloon or an OPN to crack the calcium and prep the bed, the lesion for the DCB, because there was some uncertainty following the follow-up OCT if we could leave those dissections. My boss decided to use additionally FFR to assess the flow, and there's also a lesion in the lower part of the RCA. But again, it looked nicely and we left it. And the patient came back for a follow-up angiogram because we also were nervous if you could leave it like that. Like I said, again, we treated a patient almost 3 years ago. And that was after 2-month follow-up. You can already appreciate how nicely that lesion has healed. And there was actually a lot of lumen gain. You can see that down here. Initially, the MLA was around 6.3 square millimeters. And after 2-month follow-up, we had a doubling in lumen and an MLA of more than 12 square millimeters. Here's another case where we applied our crack and coat approach. This is a 82-year-old gentleman with a history of AFib who was on anticoagulation and presented with an non-STEMI or unstable angina. And you can appreciate down here, he had a very focal and tight RCA lesion. And my rationale here was, whenever possible, avoid placing a stent here because this would have increased the patient's bleeding risk. And I went again back here. I used the OPN at high pressure. It's stupid. And that was the final angio, and he came back for a follow-up investigation because he had recurrent chest pain, which were probably not typical a few months later. And again, it looked really nicely. And the patient had been in follow-up here. He's now more than 84 years old. He never had any chest pain again. He's doing really well. So At our side, we have used drug-coated balloons in all-comer lesions for more than 4 years now. We are actually steadily expanding our practice. We're tackling more and more complex lesions, and that we are doing something safe. We're constantly investigating ourselves or monitoring ourselves. Here's a small registry data set which we had published earlier, and so there was quite old data from our side, but it was convincing to us that we were facing a MACE rate of less than 7% at 1 year follow-up in all common lesions. There will be more data from our side in the future. We have now enrolled in our ongoing registry more than 1,200 patients, and there's no signal, at least at our side, for adverse event for fear for adverse events which could put an end to our practice. What we've also observed over and over again, that by tackling fibrocalcific lesions with drug-coated balloons, that you see a late lumen gain in a majority of cases. Here's some observational OCT data from our registry, where we had analyzed data from patients who had follow-up OCT investigations. And again, we saw a significant lumen gain and healing of those nasty dissections in the majority of patients. And I've said it before, like if you're going to use more DCBs in your daily practice, either for native as well as for instant restenosis lesions, lesion preparation is key. Use intravascular imaging, use dedicated balloons. The OPN NCB will be a major facilitator in your practice, and it's key to crack the calcium. Whenever you use DCBs, don't be afraid of dissections. And that's what I announced earlier. You will face them. But by avoiding semi-compliant balloons, you lower the risk for having dissections. Avoid oversizing. Whenever you have dissections, there are certain criteria which you should respect. First of all, if you have ugly dye hanging around, bad stented, because this will result, this is actually one of the signs which could endanger you of having an acute vessel closure. But whenever you have good lumen, good flow, and an asymptomatic patient, you are on the good side, and in the majority of cases, you will have a good result. In case of doubt, use imaging or some kind of physiology tool. If you have the dissections, might go back, use modified balloons or prolonged balloon inflations, post-dilate. And what we like to do is to go back with a OPN and keep it open for prolonged time. And that's actually a very effective strategy we have learned. So I'm coming to the end of my talk. The take-home messages from my presentation should be: you need to be aware that stent thrombosis and ISR are still a nuisance and a danger for those patients who have placed stents, and especially if you implant stents, they will thrombose or at least restenose. So therefore, DCB PCI is something which will transform PCI in the near future, but for doing so, you need to invest a little bit, and you need to have adequately or apply strategies to adequately prep the lesions. Therefore, avoid semi-compliant and regular NC balloons, because they, in the majority of cases, do not adequately address the underlying lesion morphology. Crack and coat, as I said before, with the OPN and C balloon, it's not only safe and simple, but it appears to be very effective, and it will certainly transform your DCB PCI outcomes into really good long-term outcomes. So we personally believe that the goal mission of every interventionalist should be to leave the vessel uncaged, and I fully agree with the skepticism out there. There is a need for more randomized data, and we will get that data at some point. Thank you very much. And here's one final slide. Here are the number of DCB procedures which we have done over the last few years, and it's amazing. You get actually a really attached or attracted by. Once you see it works, you want to do more and you want to treat more. And over the last 4 years, our numbers of DCB-based PCIs have really exploded here. Thank you very much. I hope we can have a little bit of time for a few questions or some critical inputs. Yeah.
Thank you, Dr. Matthias, for a wonderful talk. And drug-coated balloons DCB PCI has always fascinated us regarding its concept, science, and the ease of like not leaving a metal behind. My one question to you, like when you were planning an ISR, so does the lesion imaging when you do the OCT or IOS, do you decide on the basis of what you find inside, like if it is a neointimal hyperplasia versus a fibrocalcific plaque? Does that help you in making a decision whether I'm going to stent it or I'm going to do just a drug-coated balloon DCB?
For ISR, we would always firstly aim for DCB. And that's one, and I should have underlined or elaborated the topic a little bit more. We've seen, and we've also published our observational data on that. We've seen by using DOP, and especially in ISR lesions, it's remarkable how you compress the tissue and how much lumen you gain. You not only, I apologize for that. Okay, you not only address the underlying issue, which probably triggered the ISR, but you also, as I said, you compressed the tissue, especially if you're also having neoatherosclerosis. You basically just squeeze it, and by doing so, you often have a really nice lumen gain, which you can then just finish up with a drug-coated balloon. And I think that's the kind of study which we are going to need, because there's still too much discussion about that. There are still some key opinion leaders who tell you, like, if you have neoatherosclerosis or lipid-rich instant restenosis, that you should aim for layering it with a third generation drug-eluting stent, whereas on the other hand, you have calcified lesions and you have good lumen gain following preparation with an OPN or whatever, you might use a drug-coated balloon. I think uniformly that key is to gain lumen and not having flow-limiting dissections. And if you have that following lesion preparation with an OPN or whatever, you can actually basically just end up using a drug-coated balloon. Long answer to a short question. I think.
Thank you so much. I'll open the session to ask question. Dr. Sarachandra, sir, if you would like to add some light.
Thank you, Dr. Matthias, for a wonderful presentation. As you have a very wide experience of using DCB, what is usually your usual strategy when DCB failure comes to you? It is different type of drug, or you treat with stent that time?
What we like to do at our side is, first of all, we need to understand why the DCB. We need to understand why the DCB failed. And that means to go back, use IVUS or OCT to see if it's often when we have DCB failure, we learn after follow-up that we might not have addressed the fibrotic or the calcified tissue adequately. Sometimes what we've also seen now more and more, we had a flow-limiting dissection where turbulences occurred and which might have impaired lesion vascular healing. And also, I mean, we had to learn it the hard way. In the past, we had aimed to also tackle thrombotic lesions, like MI lesions, STEMI lesions, for instance. And by doing so, you might not cover the plaque cleft or the crypt following the plaque rupture. And there we have turned a bit more hesitant to use drug-coated balloons in thrombotic lesions or MI lesions where we have an underlying plaque rupture, because we think stents are extremely efficient there to restore the vessel architecture, which is often destroyed by those crypts. Whereas on the other side, in more stable lesions or calcific lesions, you often it's more about lumen gain, which is key to have a good long-term result.
Thank you.
Can I?
Dr. Ashok, yeah, please go ahead.
Yeah, thank you. Dr. Matthias, a fantastic talk and very, I mean, certainly agree with the fact that you truly believe with the limited experience of my stay in Leucine Center last year, and your approach is slightly unique and it deviates from the standard recommendations. I mean, in an innovative direction. I mean, fascinated with that. My question to you is in the presentation, repeatedly you mentioned not to be scared of dissections. So yeah, I'm concerned if with the nodular calcium, assuming the dissection is not limiting to intima and extending to media, unless we do an imaging, probably doing a DEB and DCB and leaving the patient, they come back with the terrible outcomes. I mean, I mean, usually we experience that with nodular calcium in spite of doing the same NC, OP and NC balloons. And we may probably end up with the medial dissection, and we may not and angiographically see the dye halting as one of the signs accused that you mentioned. So your take on that?
You mentioned a very important point there, and I didn't address that adequately as part of my talk. I mean, the calcified or the calcified nodules are something of concern for every interventionalist, as we're well aware of. And especially more so there, we believe that using DCBs in such lesions might often be the best option because you won't end up with a nice result by placing stents. You will have indents following, and then you have to go back and aggressively post-dilate following stent implantation, which will bear some risk for vessel rupture or early restenosis. But I think if you're going after eccentric calcifications nodules, you should probably use some sort of atherectomy device. We like to use orbital in those cases if you have large vessels, or at least rhoda, to try to debulk it to some degree. And then we often use hybrid approaches for lesion preparation, like cutting and OPN. And we paid. I personally there was a time a bit more than a year ago when I was really fascinated by that data, which indicated that shockwave could be especially effective in calcified nodules because it goes into the depth and then we'll have more and more lumen gain. But I've abandoned that approach as well. I think what you need to have is it's all about lumen gain. And if you have a good lumen but an eccentric orifice within a vessel and good flow, you can often leave it. It's very important that you avoid overstretching the vessel in lesions with eccentric calcifications. And then if you have good flow and good lumen means usually our thumb of rule here locally is that we have the proximal segments of a vessel. You should aim for about 5 to 6 square millimeters at least, meaning prox LAD, prox RCA, the very prox circumflex, mid vessels usually 4. You're fine. Distal parts around 3, and then you're fine. 3 square millimeters, you will be fine. And then regarding your final point of the questions, again, like if I've got that here, if you look at those criteria, I fully agree with you. If you have a dissection type D to F, you're done. In the majority of cases, you need to bail out stent it. But in what we've also learned, if you have a C, by going back to prolonged balloon inflations or use a cutting balloon or a scoring balloon, you can often rescue the the whole thing and restore or optimize flow, and you will end up with a really nice long-term result.
Great. Thank you. Thank you.
Dr. Aftab Khan, for your opinion.
Yeah, so Matthias, that's a wonderful talk again. I think we've all discussed. So DCB, I think we are all moving away from stents, and I think that's as we are facing more complex patients, and with especially patients with HBR. I think most of these patients who have calcium invariably are these patients who are with renal failure, with elderly patients who have anemia and many other problems. So I think these both go hand in hand, and therefore we are not going to get much calcium unless you have HBR also associated with it. My thing is two quick questions. One is your choice between sirolimus or paclitaxel. That's one. And second is that if you have to take two lesion subsets, one is CTOs and second is bifurcations. What is your strategy for the DCB there?
I mean, at the moment, first, I'm going to take the first question, which drug? I don't know it. I personally randomize every patient. We have, at the moment, in the lucky situation, we have, I think, 3 or different DCBs on shelf.
Yeah.
At the moment, I'm very fond of the one from Translumina. We use a lot of proteges because it's very fantastic balloons in terms of deliverability. In the past, we have used other vendors. I don't know it. There will be more data out there. I mean, ultimately, one of the decisive factors will be about the balloon technology itself, not about so much about the drug. If you have a poor balloon which doesn't allow you to deliver the drug to the lesion itself, or then it already fails. And I think there are some really good balloons out there which have changed the field a bit because they have especially good catheters, and it still takes some time and some large trials which will advise us more about which drug or which excipient will change the field. At the moment, I don't know it. As I said at the beginning, it's just I use whatever I like. And one thing I know, there are some balloons which I stopped using because they have flocking, and it's especially the ones from the big US companies. I mean, some of you might have also faced those situations where you have patients with patent vessels but horrible ST segment elevations, which have no reflow following DCB treatment. And that's why I stopped using the DCBs from the big 2 US companies. That's just a side comment. But your other question, CTOs, really nice and hot topic. We love to use DCBs in CTO lesions, and as I guess the most of you are well aware that you have, especially in those vessels, you have a lot of remodeling over time. And what we've started doing over the last 5, or we've been doing for more than 4 years now, is that we usually stent. It's often necessary to stent the occlusion site, because that's where you have most recoil, and then the remainder of the vessel we just end up treating with DCBs, and works very nicely. And then you see how the vessel will grow, and by using DCBs you avoid stenting or leave stents behind which are not adequately opposed. And finally, your third point regarding
Bifurcations.
Bifurcations. I think it should be a no-brainer for us, for every one of us, to stop using two-stent strategies in bifurcations whenever possible, because it's just not worth. And I'm convinced that we will have more trials in the near future which will advise us to avoid two-stent strategies by having adequate lesion preparation. In the majority of cases, that's my personal opinion, and it's not backed up, but only backed up by weak data so far. You will have equal results with stent and DCB for bifurcations. I don't know what you think or what your experience is, but that's.
No, I think we are all on the same page. I think we all have realized we're going back to those era when we have stopped putting as many stents as we were doing earlier. I think we are going back to the era where I think it all comes back to imaging and vessel preparation. That's the most important point, I think, which has been adequately stressed by you. I think that's very, very imperative to get a good a long-term result, whatever we do. Yeah.
And that's maybe one more final comment from my side. It's also really nice for me to learn, because now PCI is getting more and more educated. There was a time when I was trained abroad or so where everyone was able to just throw in stents, and PCI has become too easy for the major. And then we had a lot of patients who ended up with ugly results, ugly long-term results. Now we're circling back, and we need to start thinking and tailor our approach and tackle lesions more sophisticated than we used to do it in the past to improve patient outcomes. And I think it's worse, and we are obliged to do that to our patients.
Dr. Matthias, if I may ask a question, this is Dr. Girish. Were there any instances you did a good predilation of the lesions, it looked great, did the DCB, and while you're treating another vessel, you see that this lesion has recoiled significantly? Have you had to deal with any lesion post DCB while you're treating another vessel in the same sitting?
Certainly, yeah, quite often. Like what we also do, it allows you a little bit to observe how it behaves, and we might go back then once again, or also every once in a while, and I'm not saying that you can tackle every lesion with a DCB. In case we end up with some recoil, 20-30% residual stenosis, we might ask the patient, listen, it looks good for now. Are you willing to go back? Do you allow us to do a follow-up angio? Or also, if we have dissections and there's some uncertainty, we might ask the patient, hey, listen, we could stent it, or now at the moment it looks good. We don't know how it will look in the near future. There's a bit of dissection. We suggest that we have a follow-up angio. And then also, there are those lesions where we might go back, optimize a little bit, do a bit more of aggressive post-dilatation following DCB treatment, and afterwards it looks good.
Thank you.
So wonderful discussion, Dr. Bossard. One last final question I just wanted to understand from experience, like which are the lesions retrospectively you thought that while doing you thought DCB is good, but retrospectively in follow-up you thought stenting would have been better. So if you can highlight those lesions.
Very thrombotic lesions, as I mentioned before, STEMI lesions. I know there is a trial ongoing in Europe where they assess the utility of drug-coated balloons in STEMI patients. This might change over time because we now also have more effective thrombectomy devices. Lesions with ostial lesions, I need to mention that, are ostial RCA lesions. There's too much restriction or too much restrictive force in the majority of cases, and also ostial left main. On the other hand, distal left main lesions usually work very well. As I said, bifurcations, CTO lesions work very well, and diabetic vessels. Those vessels usually also have a really good outcome, or at least in our experience, often show a good outcome with DCB treatment, diffuse disease. And by using DCBs, you actually treat more than you would treat with stents, because with stents, we still have the tendency to just treat focal lesions, whereas DCBs allow you to treat long segments, and you might have the potential to transform the plaque by itself. But there's also that's early data or early insights from observational studies.
Thank you, Dr. Bossard. Can I one small statement? Especially in Indian setting, also we are using DCB of crack and coat strategy. Only we are restricted to layer type of ISR documented by OCT, not neoatherosclerotic. Only layer type, homogeneous layer type of neointimal hyperplasia, number one. And number two is a small vessel plain balloon angioplasty followed by DCB. And third one is in bifurcation, rostral side branch. These three subsets we are using in India not as aggressive as you are doing the DCB crack and coat strategy.
Interesting.
Thank you.
Do you have
Dr.
any
Prasad, for a
restriction?
very nice,
Do you have any governmental restrictions to use DCBs, or in terms of reimbursement? Is that at some places in India an issue? It is?
Because it is out of pocket in India.
Oh, yeah, it's yeah, no, I can imagine, yeah. Mhm. And it's also where like stents are almost for free here. I need to be open and disclose that as well. I mean, the cost of DCBs are still a big issue because a DCB is 4 times the price of a DES, at least in Switzerland. Yeah.
Sir,
Yes.
I'm Dr. Bhanja. Sir, have you any experience where you are in primary PCI, where you are not putting a stent, just doing plain balloon angioplasty? So is there any role of DCBs in these cases? Have you any experience?
That question was for me. So
Yes, yes.
yeah, we have done that. That was something which we have done in the past a few times, and that could work where we have restored flow, and then we had a good angiographic result. There was some angiographic evidence for residual thrombus, but TIMI3 flow, and we thought, why don't we bring him back anyway in patients, especially in patients with multi-vessel disease where we wanted to treat anything else. And then we went back and we assessed the lesion, might have used some some intravascular imaging, and afterwards we thought, okay, it looks good lumen gain, do a little bit more of lesion preparation, fix it up with a drug-coated balloon. We've done that a few times in the past. But again, like often it's hard, especially if we have a lot of patients who present rather late with MIs here, and then you have organized clot, and there it's hard to restore flow without throwing in a stent.
Thank you, Dr. Prasad. It's an interesting topic. I think questions will never end. But in the interest of time, I think we have to move forward. I would request Dr. P.L.N. Karpathy, sir, to start his talk over safe stretch with ultra-high pressure balloon dilatation. Over to Dr. P.L.N. Karpathy.
First of all, I should be thankful for giving this opportunity to this industry for this educational platform. And most important, I want to present this OPN in two representative cases. I want to present this OPN balloon role. Am I audible and visible? Hello? Hello?
You are visible.
Hello?
Yeah. You are visible.
So, yes, two different settings. One is a lesion preparation where the balloon is crossable, but stent is unable to cross, looking very simple PCI. So in this setting, actually, sometimes a poor visibility of the fluoro also sometimes play a role in this inadequate preparation where OPN plays a significant role. So with this heading, I want to present one case. So the patient is a 75 years old gentleman having risk factors of diabetes and hypertension, having and smoking, and he presented with a chronic stable syndrome of crescendo angina with inducible ischemia and GMT with good LV function, had a basin angiogram which is showing a circumflex OM, especially OM 85% tight lesion in the circ extending into the osteoproximal OM. So this is the angiogram which you can see basin and angiogram. Patient has a OM and OM2. OM seeming very simply, and OM2 is also a tight lesion. And first we want to do the OM1. It seems okay, pre-dilatation with 2.5 millimeters balloon. It looks like a dilated. Still lesion is persisting. So what we thought is it is adequately dilated, and we want to pass the stent, but stent is unable to cross. In spite of the good backup that is the XB catheter as well as the guide extension also, we are unable to pass the stent. So we thought something is different. So then we have taken the open NC balloon dilatation was done almost to 20 atmospheres, 2.5 into 10. So once this was done, stent becomes easily crossable, and then we can able to deploy it. And then aggressive post stent was done, stent dilatation was done in this given case, where patient had sorry, so it is unable to this one, unable to now you can see aggressive post stent dilatation was done with a NC balloon. Then what we observed, very important, once after a important balloon dilatation, he is unable to, it is unable to that. Patient has a small intramural hematoma after aggressive post-stent dilatation. Whenever we have seen a good preparation, if you do aggressive NC dilatation, then after stenting, if you do aggressive NC post-dilatation, patient may develop sometimes perforations or intramural hematoma, which here unable to document because of the it is not running. So this is one case. It's a lesion preparation where sometimes because of poor fluoroscopy, we think it is dilatation. Everybody day-to-day practice we will encounter. This is one case I want to present. And the second important one which I want to present is the second case where after stenting, this is also one of the important cases where OPN plays a significant role. So this is also circumference angioplasty. So presentation chronic syndromes and proximal circumflex is a tight calcific lesion. So this is the one you can see, put the pacemaker, and after passing the wire, we are unable to, because of bent lesions, basically calcific bent lesion, where along with the support, guide extension is needed in case, and then you can able to see this one.
Yeah,
and
yeah,
then here, with the help of the guide extension, the balloon is able to cross, and the stent, it is difficult to pass here, and with the help of guide extension, we pass the stent also, and then deployed the stent. And then after stenting, there is a classical unexpanded stent at the lesion site we can able to observe. And here what we did is, with the help of the guide extension, we can able to pass the OPN, and then you can see that we dilated at almost 22 atmospheres. We can able to stretch the unexpanded stent, and then ultimately we got a expanded stent in the calcific lesion. So this is another indication. First is the lesion preparation inadequate, where OPN plays a significant role because maybe quality. And second thing is patient with the bend, where the devices are difficult to pass, very, very important. So you have to take sometimes the guide extension catheters, and OPN plays a significant role in balloon unexpanded stent. The OPN plays a significant role. Even at 16 to 20 atmospheres, you can open, where NC balloon, active force, I have seen the best post stent dilatation, the NC balloon. With that, even 28, 30 atmospheres, the lesion won't yield. The OPN at say 16 to 20 atmospheres, it will yield, and so that we can give the good result. So this is one, and case, just 5 minutes. Is the time is over?
Yes, actually, we are running short in time. So,
Okay, sorry. So these are the things which usually, and third one is as a device energy. In that case also, we can able to have this OPN as a significant role, especially when using post IVL. So just 1 second, I will present that one, and I have where this has an important role actually. Sorry. So as told, this is another important case. Just I want to just briefly present that one. So this is a patient presented with an acute anterior with a calcific lesion. You can appreciate. And then what we did is, sorry, we passed the wire, and then you can see the transfer calcium here. So after passing wire and balloon dilatation, you can see preparation, and then we put the James stent. You can appreciate how this one, you can see the calcific tight lesion preparation. Then patient developed actually when during stenting, he had arrested, we did CPR and TPA, and then you can eat waste yielding, then we put the stent, and then after putting the stent, then we observe the gross unexpansion stent, especially at the portion. You can appreciate here. Yes, you can appreciate unexpansion still. And then with the NC active force balloon, we dilated almost 30 atmospheres. And at that time, patient is relatively sick, actually. Then what we did is pre-dilated with the OPN balloon so that it facilitated the IVL. So this is the situation where you can use IVL for underexpanded calcification. The tent underexpanded the calcification. You can observe almost we have given 8 cycles was given with C2, and then you can appreciate how dense subadventitial calcium with an underexpanded after OPN and IVL, you can see how it expanded. So this I want to say the OPN role is there, especially even after IVL also for preparation for crossing of IVL, and as a device energy, it is very, very effective in a dense calcium with unexpanded stent. So these are the ultimate final result with a good thing. So these are the 3 subsets I want to present where the OPN is used in lesion preparation and underexpanded stent in calcium. Sometimes for underexpanded device energy with both OPN as well as IVL, which plays significant role. Even in acute MI also, we have observed this type of advantages with the OPN. Thank you.
Thank you. Thank you, sir.
Thank you.
Wonderful cases, beautiful result. And we are sure we have many questions to ask, but I think in the interest of time, we'll proceed with all the talks and then we will keep questions in the end. So I will request everybody to be present. And the next talk is by Dr. 𝐂𝐨𝐥𝐥𝐨𝐪𝐮𝐢 over importance of OPN and C in chip cases. Over to you, Dr. 𝐂𝐨𝐥𝐥𝐨𝐪𝐮𝐢.
Thank you. Thank you, sir. Good evening, sir. Giving me the opportunity to present a simple case. I have 2-3 cases, but because of lack of time, I will just present a case from imaging guided because CT guided. Sir, you can see the this is the LED lesion. It is a 57-year female. It's a diabetic hypertensive post menopause, chronic stable angina, class 3 angina. TMT was strongly positive, so we will take the cases for coronary angiogram. And though the lesion was looking like the simple, so initially just after wiring we did balloon, but there is you can see this is a post tightest lesion just distal to the diagonal. Next one. So this is the normal after wiring the balloon. So I thought we can easily stand and I will come out, but I will show the positive images. First, you show how the beautifully dilated the region, then I will show the acid. Only preview I are not there in the images. Next one.
This post-plastic, yeah.
You can see this. Can this be preview? Then I took the stand of 2.75 and 23 giant Sierra. Then I deployed the stand with normal pressure, post-dilated with the velocity. Then we'll go to stand. Let's go. This is stand boost, you can see. Then I took the balloon, NC balloon, 12 millimeter, 3 balloon dilated up. You can see even after post dilatation, it will see the stand boost. It has not opened properly the mid part of the stand. Then I have to take the OPN and I will show to the post. This is the final result, and I'll show the post OCT, post stenting OCT. You can see the post stenting OCT. Actually, though initially sometimes what happens, the why imaging is important, though you thought that we can do it and simply put a stent and dilate it, but many times we land in trouble. So I think OPN is a good help in these cases. I have another 2-3 cases because of short time. We have OCT at TN2. So usually some calcified lesions are we are not able to do the proper stenting, or even after post dilatation. We used OCT. So in OCT, you can see this how the beautifully deployment of the stand and with OPNs. So basically, my question to the house, and also though I have used a lot of OPN in cases, but I have less experience than others. Just I want to know how you will choose this post dilated during. Suppose I have not dilated, pre-dilated, I have not this lesion properly, and I have landed in problem. So what should be the size of the OPN to the stand, whether it is 1:1 or it is 0.5 less, if I have not used in pre-dilatation OPNs. Because I used to take 1:1, and for this patient, I have to go up to 35 to 40 to properly the optimization of the stance.
I mean,
Because
Yeah.
this was probably a nodular calcification, so I wish to come out of this problem. So, is there any experience of where you have a long calcified lesions? So, but you have not initially you just properly pre-dilated with OPN-NC, and after putting a stent, if you land in problem, not able to properly optimize the stents, what should be your experience with OPN-NC?
Dr. Bussard, are you there? Would you like to take Question?
Yeah, I think what we've learned over time, and also there was a study which was published by Florim, my boss, actually in the past. It's called OpenBIS study. You can look it up, or they call it also pre-NC study. What we've learned is once if you don't prep the vessel properly, or if you don't use adequate lesion preparation, following stent implantation, you won't be able to overcome the limitation, and you will have a worse final stent expansion. That's something which we have published about 6 or 7 years ago. And by doing so, what we usually do is use the OPN for lesion preparation. And if you have a 3.0 vessel, but there's and we might use a 2.5 OPN at very high pressure, meaning can beyond 35 atmospheres, 40, whatever it takes, but to strictly downsize it to focally crack the calcium, and then go back off. In almost all cases, we use intravascular imaging to assess what happened following lesion preparation, to understand if you need to go back, use a bigger balloon, and then if we're happy with the result following lesion preparation, we will place the stent, and then in the majority of cases, you only have to post-dilate with a regular NC balloon, or as often also a semi-compliant balloon will be sufficient to just adjust or to adapt the mala position. But if we have to post-dilate following stent implantation, I would also always go down at least 0.5 millimeter and aim for not in order not to oversize or overstretch the vessel. It's more about pressure than about size.
Right. So I think we have got the answer that once we have erred in making a less prepared bed, and if you deploy the stent, we can't achieve the best optimum result.
Exactly.
In that time, probably rather than rupturing, rather than landing in stent fracture and perforation, it is advisable to downsize by 0.5 mm, go with a very high pressure. Like in the earlier slide also, where Dr. Broussard has mentioned, lesser size and higher pressure. And then with the optimum size of NC, you can go ahead again and can optimize the result. So anything else you want to add, Dr. Bhanja?
So just my question is that if imaging is available, it is most important you should help. With our optimization is basically either OCT or IVUS. That my experience is basically imaging is most important in optimizing these stents. Though we are using OPN, anything we are using, but still we will miss many things without imaging. If available, then we think we should avail this opportunity to give the best result to the patient.
That goes the absolutely point well taken. Any complex reason, I think imaging makes your plan easier, and it makes your work easy to plan it accordingly. What needs next? What is needed next?
Because in this case, if I didn't have imaging, probably I will leave the patient with some NC balloon. Because of imaging, it is easy to handle, and definitely we are able to optimize this stent very nicely. Whatever my experience I am saying, because it is not available in all labs, so that is also most important thing. And cost is also an issue. You are using OPN, you are using imaging. So a single vessel angioplasty, if you will charge heavily the patients, also we have to do the patients. That is also most important. So you have to be very calculated to do the PCIs in small to medium cities patients.
True, but you could manage a very good decent result at the end. So congratulations for that. Good. Maybe proceed to the next talk, Dr. Parminder Singh. Interesting cases of OPNNC. Do we have Dr. Parminder Singh with us?
Parminder Singh sir is not there. Sir, we can have the next speaker, sir.
Dr. Ashok Kumar.
Yeah, he is there, sir.
So Dr. Ashok Kumar. So he'll be talking on Nick Nano, a boon for CTO lesions in complex PCI. So no doubt that goes without saying, TransLumina has brought some interesting technique like IVL, OPNNC, and this Nick Nano. Where everything fails, this Nick Nano enters. Even sometimes the microcatheter doesn't go, and the Nick Nano helps in achieving the balloon dilatation and crossing the lesion. So over to Dr. Ashok Kumar.
No, thank you, Translumina, for the opportunity. I mean, it'll not take much time, probably only a few minutes, because it's going to be a repetition of more or less the same, actually, emphasizing on the same. Few cases, I mean, only this is a 70-year-old gentleman with antral MI taken for primary. I put this
Sir,
case.
sorry to interrupt you. I think we cannot see your screen. Is everybody else able to see the screen? It's still showing started screen sharing, right? Can you just share it again? Yeah.
Is it now? Can somebody help me with that?
IT team, can you just check if you are able to see the screen?
Yeah,
Yeah,
yeah.
now it's visible. Now we are able to see, sir.
Oh,
Yes. Thank you.
thank you. I mean, I'll quickly rush through. This is just to display that there's a case of Antroval MI, elderly gentleman. We can see there's a sluggish flow after initial pre-dilatations and reposition. And wire reposition properly, we can see there is a there is a this is a calcified lesion. And usually in primaries, we don't tend to dilate or over dilate or just put a stent, stabilize the hemodynamics, and come out and probably retake the other day in case we anticipate a under expansion. But what my understanding, especially in calcified lesions, even with the sluggish flow, we can afford to take this opium balloon, because this doesn't actually dilate and onto the non-calcified site, or I mean, even in the calcified lesions, it dilates uniformly, so that we don't experience tissue prolapse or plaque prolapse, and contributing more to additional burden of sluggish flow or slow flow. So, I mean, this case, I mean, after putting a stent, probably, fluoroscopically, we see the calcific burden on stent under expansion, and this better manifested in stent boost images as well, even if we don't have in-house facility, which is a huge limitation majority of the centers in a developing countries like us. So I dilated the lesion with an opium balloon and optimal expansion, and so that I could probably avoid one more I mean, one more procedure, or one more a day of re-intake into the cath lab for optimal expansion or adequate post dilatation. So the similar case, elderly gentleman presenting with, I mean, this is a 88-year-old gentleman presenting with NSTEMI and significant chest pain, and trop is positive. And we can see this is a calcified LAD lesion, critical tight lesion, calcific tight lesion. So not yielding much with the regular NC balloons. Then I took opium balloon, went to higher pressures 30, and then that helped in dilatation. These are post-stenting images. Even if post-stenting, probably, this part is not initially dilated. This part, proximal part, is not initially dilated with opium balloon. Only the distal part, because this was the highest, tightest part. So I dilated only this part with opium balloon. Then I, with the stent boost images, I did the post-dilatation as well with the same opium balloon, which I consumed in the for pre-dilatation as a tool. So then finally, eventually got a good result. That was a spasm that we saw in the previous shot. And we can see, I mean, calcium is cracked and stent is placed, and when there's still there's as calcium in the subintima, probably imaging would have helped me in I mean, looking out for MSA and probably distal dissections or something. But I was happy because 88 gentleman, he was stable. And then because I didn't have in-house imaging, I left it as such and followed him, and he's doing good for a couple of months. So this is a reattend procedure, post CABG patient, 68-year-old, I mean, very significant angina, are very day-to-day activity limiting angina. RCA graft is occluded. I took him for, RCA is actually, RCA is a CTO. I opened a CTO with a fielder balloon, but in spite of repeated attempts, they could not crack this calcium. In fact, I attempted bursting the balloon as well, but I could not, pass the balloon across through this. So this is a second procedure as a patient second and second day. Because a calcified lesion and balloon, even one balloon could not be crossed. I did this with a rotablation. So after runs of rotablation with 1.5 bar, I placed a stent. And again, this is a limitation without doing a procedure without imaging. I thought I could crack the calcium adequately and then dilated with the 3 regular NC balloon. I thought achieved adequate expansion and then deployed the stent, only to observe that this part, if you can observe, if you can see this clearly, this part is clearly under expanded. In spite of doing an adequate rounds of pre-dilatation with the regular NC balloon after a rotablation, because it's a hard, encased calcium around. So then I had to borrow for post-dilatation. I had to borrow OP and NC balloon. Again, to minimize the cost, probably I didn't go with the. I usually go with the indeflator that OP and NC. Only if the 30 pressure with a regular indeflator doesn't crack. So fortunately for me, at 30 atmosphere, this OPN actually cracked and dilated the stent, and so that gave a good result. Final case, more or less a similar case to the third case. Calcified RCA. This is elective procedure. So because it's a track and calcium throughout, so I did with the rotablation and then stented, but only to observe that, post stenting, we fortunately get post stenting stent boost images very precisely and very much better shape, and that displays stent under expansion more clearly. And then I observed that stent is under expanded, significantly, especially at the point that, at this proximal curvature. So, that did not crack with the regular NC balloon. So I had to bring in OPN NC balloon, and at 30 atmospheres, it cracked, and it dilated, and finally got a good result. So, nothing precise, or this is again a regular case, is probably in continuation with the previous speakers. Only addition that probably I brought is it can be used, or I feel it can be used even in primary PTCA, especially if the if the culprit lesion is a calcified lesion, without worrying much about the tissue prolapse. Unlike the regular NC balloon, which is still a semi-compliant or semi-compliant balloon, so which can actually worsen the slow no reflow. Probably that can be better handled with the open NC balloon as well. Thank you.
Thank you, Dr. Ashok. That's an interesting observation, particularly regarding this primary PCI thing. And this was definitely a new learning for me. Like, this can be used, but the thing is that in primary PCI, particularly when our back is against the wall, we have to use all the modalities. We have to achieve the flow, and only then we can come out. But
Dr. Abhishek, can I have one important observation comment?
please, sir,
Even
please,
routine NC balloon at 30 atmospheres, if you take a head-to-head comparison, the OP and NC balloon can generate more force with the without increasing the size of the balloon. It can open the stent. Actually, which he had demonstrated, even it is 35 that indiflator is not available. At 30 atmospheres, OP and NC opened up the stent. So this is the final observations we have seen with routine NC balloon. Even 30 atmospheres are unable to open. Open NC, even 16 atmospheres it can open.
We can actually to bring your cases back, because in your cases also we observed in the LCS, you could open with 20 atmosphere open NC, and with normal NC it was not opening. So we observed that, and this double layered probably with more uniform pressure application over the lesion, it certainly helps. So point well taken, and I think this is useful for all of us.
Thank you.
We'll keep the questions in the last. We still have 3 more talks to go. So thank you, Dr. Ashok. Wonderful cases.
Thank you, Dr. Abhishek.
Thank you so much. And Dr. 𝐂𝐨𝐥𝐥𝐨𝐪 for OPN NC in notorious ICR lesions. Dr. 𝐂𝐨𝐥𝐥𝐵, do we have Dr. 𝐂𝐨𝐵 with us?
Yeah. Good evening, everyone.
Good evening, please.
Yeah, very good, Dr. Sheikh.
Over to you.
Yeah, thank you. Not able to share the screen.
Mr. Ritesh, if you can help.
Sir, any challenge, sir?
IT team is there, sir. Studio team, can you just check if we can share sir slide? Sir, can you just click on the green button?
Yeah, I'm sharing the entire screen, but the share option is not. I'm not able to click the share option. Only cancel option is open to
Okay.
me.
Sir,
In the center, you're having this green button.
you said the green button is there.
Yeah, I I I clicked on the green button, share the screen. Then after that, it is not sharing the screen.
Sir, after that, you can see the entire screen option. Click on that, and on the bottom, there is a share thing.
Just a minute.
Yeah, it started coming, sir.
Yeah,
Is
at the
it
bottom.
visible?
Yeah,
Right,
open the slide, sir. Open the slide.
Hello.
OPNNC in ISR region उसको खोलिए, sir.
Yes.
सर आप ना सर उसको पहले खोल लीजिए सर. स्लाइड को ना
Hey,
सर पहले ही खोल लीजिए.
Yeah, I opened before, but now I went to another.
And share के बाद जो
is it visible?
सर आपको visible है लेकिन slide is not.
We can see whatever is there on your screen. So if you open the presentation on a screen, we would be able to see that.
तो क्लिक करिए सर. स्लाइड को क्लिक करिए सर.
If you can click that slide.
हाँ. सर एक काम करते हैं सर. हम लोग दूसरे स्पीकर को ले लेते हैं. सर को हम लोग रितेश कैन यू कनेक्ट सर डायरेक्टली and then maybe help
I'll
him
just
with
call
that.
him. I'll just call him.
Yeah, please. So,
So we
do
can
you
have
have
the next
Dr. Devapriya Mandal with the role of OP and ANSI in pre-dilatation? Dr. Devapriya, are you with us?
Sir, you are muted, sir.
Yeah, good evening. I'm there. The only thing is probably if the slides can be shared, it will be very easy for me.
Okay.
Sir, so have you shared this slide, sir, to some of my colleagues, sir?
So I think Joy from our end has already been informed about these slides.
Okay. Sir, maybe if you can...
Sir, it's I'm sharing, sir. I'm just sharing.
Okay,
I'm actually
Ritesh. Ritesh, go ahead and share it.
Yeah, I have the slides with me. Yeah, just share.
Yeah. Please go ahead.
Okay.
We can see that. Please go ahead.
Go ahead.
Okay, so good evening. It's a wonderful discussion which was going on. I could hear almost everything out of it, but then I missed certain parts because there was a meeting going on. Now, hello, can you hear us? Can you hear me?
Yeah, we can hear you now, sir.
Yeah, you are.
Please go ahead, sir. Please go ahead, sir.
Hello?
Sir. Please go ahead, sir.
Yeah. So now what happens is OP and NC balloon we have been using for almost last 4 years or 5 years or so, but then the usage of OP and NC was mostly restricted to the post-dilatation purpose. We are not using mostly in the pre-dilating segment. But then I was listening to the first talk wherein the lesion preparation in the average individuals who reach up to us in the cath lab is important. So we cannot charge everything for every patient. So what I mean to say is some patients will always have calcific lesions, mostly fibrocalcific lesions, and we cannot charge a cutting balloon, and we cannot charge a OP and NC, and we cannot go about doing all the tech-savvy devices which we have in our shelf. So probably in those settings, the usage of a OPNNC balloon would be very helpful in preparing the lesion bed before deploying the stent to prevent any untoward complications in the pre-dilatation part as well as in the post-dilatation part. So I was listening to the first talk wherein the dilatation with a semi-compliant balloon can actually lead to nasty dissections, which we infrequently come across. And then if we have to take up those cases, we have to select those cases properly. If at all those cases are doable with a balloon itself, which we can utilize any of the calcium algorithms and then decide whether the balloon itself can take care of the lesion. And if yes, we can actually use an OPNNC to take care of the lesion per se. So while using an OPNNC, we have to avoid the polymer sleeve wires like the Fielder XT and the Whisper. For accessing the distal lesions, using an extra support guide wires like a Grand Slam is an important strategy. For pre-dilatation, using a 0.5 millimeter lesser diameter balloon than the reference vessel diameter. For post-dilatation, it is always 1:1 size of the OPNNC, specifically in the in-stent restenosis. And to be used with the OPN ID, this is the inflation device with a working limit of 55 atmospheres for optimum utilization, and increasing the pressure gradually after reaching 20 atmospheres. So this is very, very important. What we commonly do is we use 2 wires and then slowly inflate beyond 20 atmospheres, looking into the hemodynamics as well as the possible consequences. So here I'm going to show you a very short case wherein I had utilized the OPNNC for pre-dilatation and achieved a good result. Next slide. Next slide. So this was the case history. He was a 70-year-old gentleman. He had a history of anterior MI some 7 months back. The primary PTCA2, the left anterior descending artery, was done in a separate hospital. He is non-diabetic. He had triple vessel disease, and then he came up to me to tackle the right coronary artery. His left system was good. ECG showed RVBB, left anterior fascicular block, ejection fraction of 45%. Risk factor was hypertension. Next. 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 So this was the angiographic view. If you can understand and if it is clear, this patient was having a tachycardia of around 110 to 112. The pictures may not be clear. There was a definite visible calcification which was noted in the mid part, proximal and mid part of the RCA. And the discussion was whether we are going to utilize any of the calcium modification strategies. So obviously the plan could not be done without an imaging, and we had utilized IVUS imaging to see the lesion. Next slide. It was wired successfully with a normal standard workhorse wire. Pre-dilatation was done with an alveo-NC trachea and OPN-NC 3x10 balloon. So the whole concept was we are going to utilize one balloon and which will take care of the entire lesion. So this lesion, however happy or however sound it looks like, whenever we tend to deploy a stent before preparing the bed properly, there definitely will be an under-deployed stent in the mid part, and these lesions definitely will come back after 6 months to 1 year with an ISR lesion. And so multiple views, multiple complementary and what we say as the 90-degree views were taken to look for the adequate balloon inflation, and then subsequently IVUS was again redone. Show the IVUS. Next. So this was the IVUS run post OPN-NC. As you can see, the lumen area was less. The IVUS run is not there. Post OPN-NC, there were definite, the fibrocalcific areas yielded well. There were certain areas of calcification in the 7 o'clock to 10 o'clock segment, which showed a definite pushing and definite slight cracks in the calcium layer, definitely causing an adequate lumen area before we deployed a stent. So specifically when we see that the lesion is fibrocalcific, as was this case, the usage of a pre-dilatation balloon in the form of OPN-NC is definitely a good choice, because we are not going to get any unnecessary dissections or any unnecessary ballooning with a standard this thing. And we can also avoid the usage of a cutting balloon if you're using an OPNNC very carefully in these sort of patients. Next slide. Next. So this was the drug-eluting stent deployed. Next slide. Next. 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 Next slide. So see, other things are standard and routine, and what we can see is after the post-dilation in the mid-RCA with a pot PTCA balloon of 3.5, proximal part with a quantum apex 3.758, a beautiful RCA without any dog boning, without any residual stenosis. 2 stents were deployed because it was a long fibrocalcific lesion, and these lesions are actually very prone to developing ISR. If you have a fibrocalcific lesion, the data says the incidence of instant restenosis is very, very high. Next slide. So final post-IVUS result, please run the IVUS. Play this, please. So you see it's a beautiful RCA. Both these stents are patent, and we see a good result RCA with a good IVUS findings. So I think I'll finish here. The only message from these kind of cases are OPNNC is a good choice after imaging if it's a fibrocalcific lesion. Don't underestimate calcium if it is present in the mid part of the RCA, specifically if it's an angulated RCA, because definitely long disease fibrocalcific lesions may definitely come back with an ISR in the long run, and proper selection of the balloon is of utmost importance. Thank you so much.
Thank you, Dr. Mondal. Wonderful case. And we all have seen the better result you give in cath lab, it is the less likely patient will come back. So it is the best. Cath lab is the best place to optimize. If you're finding something suboptimal, that is the place. Take next step and optimize your result as best as we can. That is the best certainty that my patient will not come back early with some unexpected complications. So wonderful case and very beautiful result, beautiful RCA indeed. Dr. 𝐂𝐨𝐥𝐥𝐨𝐪, I thank you. Dr. 𝐂𝐨𝐥𝐥𝐨𝐪, are you ready with your presentation? Ritesh, technical issue has been sorted out.
Yes, sir. Dr. 𝐂𝐨𝐥𝐥𝐨𝐪, can we try again? वो share करके I have
yeah, right.
Yes, sir.
So दीपक एक बारी सर का slide share नहीं हो रहा है. So just when he's trying to share the green button, उसके बाद slide show में नहीं आ रहा है. तो एक बार try करो अगर वो हो जाता है.
हाँ. क्लिक करके entire screen and फिर नीचे share करो हो जाएगा सर.
नहीं, नीचे share वाला option
उसके ऊपर आप क्लिक करो सर. Yes.
क्लिकेबल नहीं है नीचे वाला ऑप्शन.
सर आप किससे कनेक्टेड हो? iPad,
लैपटॉप
होना चाहिए सर.
Cancel only is.
You have to make him host.
No, sir.
So
try and make him host.
Your side something. Because we are getting only cancel option. Share option is fainted out and it's not clickable.
Deepak, can we do one thing? Just make sir host.
Yes, we are doing it. We are doing it, sir.
Yeah.
Make him host.
Yeah. Now, sir, we can try now. Try now.
Yeah.
Thank you, Dr. Abhishek. Seems to be a good idea, sir. Seems to be a good idea. Let's see if we can share the screen now.
I have a suggestion in case if this is not working, probably doctor can share the slides. Mail the slides to the organizers.
Yeah.
Meanwhile, others.
Sir, can you mail us the slides?
Yes, Togash, best way yoga. I think what Dr. Ashok sir is saying is right. We can put your email ID, Ritesh, in the chat box. Sir will take from there. In the meantime, we can have the others.
I have sent them on WhatsApp.
Yeah. So Ritesh, you coordinate with Dr. 𝐂𝐨𝐥𝐥𝐵. And do we have Dr. M. Srinivas?
Yeah, sorry.
So Dr. M. Srinivas will be speaking over OPNNC in mid-RC calcified nodule. So over to you, Dr. M. Srinivas. So by the time I think Ritesh prepared Dr. Tejvi's talk, Dr. M. Srinivas, over to you.
Yes, sir. Are my slides visible to you?
Yeah, absolutely visible. Please make it full screen.
Okay, right. So this is a very short presentation. So on just a few slides, I won't take much time. So the angio was done elsewhere, and the case came to us for the RCA
ये
mid
जिससे
RCA
आप
plaque.
कनिका कनिका जो भेजती है जिससे उसी पे भेज दो ना.
Okay, so let me continue. So as you can see from my angio, the mid RCA lesion looks very simple at the outset, basically. So we thought it's a simple lesion. Let us start with this. So we started with the 2.5 NC predilatation. As you can see, from the angiogram, the RCA is the PDA is very proximally arising, and the RCA is just continuing as PLVB. But apart from that, we had something like, if you see the angio on the right side, the lesion seems to be opened okay, though there is a stenosis there, there seems to be some haziness. So I thought maybe there is a dissection there, so I'm likely to get a good result in spite of the nodule there. So if I put a stent, maybe I can achieve a good angioplastic result. So 2.75 stent was chosen, and when I deployed the stent, as from the expansion of the balloon of the stent, the lesion seems to have opened nicely here. But after the stent is deployed, you can see the lesion, the calcific nodule still persists there. So as usual, I took a 1:1 2.75 there. So with the same balloon went up to 30, 2.75 balloon, and seems okay here. So all is well. So for the final angios took a lateral shot, and you see that the lesion, the nodule is still in place, as you can see from the dog boning here. So of course, this was the last angio where in the lateral view, the calcific nodule is still in place. So the stent, as let me remind you, is a 2.75 stent. So I didn't find the guts to take a 3 balloon there. Sorry, this is a 2.75 stent. So we opted for an OPN balloon. OPN balloon, unfortunately, doesn't have a 2.75 balloon. So took a 2.5 NC. And since anyway we can go to 30 with the previous balloon, NC balloon, went up to 35, but still the lesion doesn't crack. As you can see, the calcium you can see on the lateral part of the stent here. So same balloon, now we went up to 45, and then we had a good result. So this is just a simple case to just tell you that what couldn't be done with NC balloon at 30, we could do it. We slightly apprehensive when we go to high pressures at 45. So OPN balloon helped us here. So this is simple short case. Thank you.
Thank you. Thank you so much. Dr. Bosard, are you there?
I'm there, yeah.
So if you are finding a case like this, which have been just shared, like if we deployed a stent and now we are noticing finding or in imaging or finding retrospectively that some calcific nodule is there. So what would be your approach? Like you would be going with OPNNC at 45? Would we do something different? Is there a risk of perforation because this nodule is not going to go? So if you go at a very high pressure, is there a risk of perforation? What is your take on this specific case?
Yeah, like as I said before, going directly for aggressive dilatation in calcium nodules, at least again, like that's my experience. I had like a few arteries which ruptured. Because what happens actually is like you're almost puncturing the artery by pushing away the nodule. Therefore, again, like the message is, that's what I think in many cases it's valuable to first attempt to have a bit debulking, and then go for dilatation again. Like also be mindful about balloon sizing, because you can easily get fooled by sizing your vessel to the largest diameter size. Always in eccentric calcifications, it's more so important to downsize the balloon diameter, because again, you will never have a round shaped artery again. You will always have an eccentric lumen, always, or in the majority of cases. And what you basically need to have or aim for is to have some sort of lumen again, which sizes adequately to the lesion location, as I told or suggested earlier, to have in the distal vessel maybe 3 square millimeters, more prox part 4 to 6 square millimeters or something. But my message will be mindful about oversizing, overstretching the vessel. Rather go down again, as I said it multiple times before. And aggressive dilatation can be helpful in some cases, but never opt for oversizing.
Dr. Bossard, this is Srinivas here, just presented the case. What we commonly notice in pre-dilating a lesion, calcific spur, is there is a dissection around that. Still, it appears as non-cracked. So here, would you just achieve IVUS area of adequate IVUS area and leave it, or do you go for an optimal result there?
No, again, like if we, as I said before, if I see it's not opening, but you have a lumen which is acceptable, I would rather leave the lumen which I have gained and accepted, and aim for DCB treatment to silence the roughened up surface, and then instead of placing a stent. But what I also calcium nodules are a pain, and it's always something. It's trial error in many cases. Sometimes you can need to go back, and if you see there's also some fibrotic or thrombotic parts involved. But if you have fibrotic parts, maybe go back and use a little bit of cutting, which could cause some cracks, and then go back with the OPN again and attempt to open up the whole thing a little bit more. I don't know what your experience is with IVL in those lesions, because it's something which is heavily advocated at the moment by many experts or so-called experts in the field. I personally see no difference in comparison to the OPN. I have a sense that a hybrid approach of modified balloons in combination with high-pressure balloons works best in following a bit of arterectomy if necessary.
And by the way, thank you, Dr. Bossard, for the wonderful Swiss Alpine background you are providing us.
Thank you very much. Can I ask you, what is the opinion on by the other colleagues here in the round? What do you think about? Do you observe that shockwave might work in those cases? I don't know. Like, I feel not, but yeah. No research.
Dr. Ziad is a big propounder of IVL in calcific lesions.
Because the company tells us, which tells it, and there will be multiple IVL devices available in the near future, and they tell us that those shock waves, actually, they go into the depth, which is something which we're aiming for to achieve some damage or actually some cracks. And those so-called microcracks will ultimately help us to open up the lumen in eccentric calcifications. But I don't see them, I don't feel them, and I have similar results or even better results if I go aim for aggressive dilatation with OPN.
Dr. Bossard and Dr. Mova, can I have one important comment with my limited experience? For all calcific nodules, you have to shave it and then crack it by means of IVL. Pure IVLs, we have good result acute, but recurrence is very high within 4 months, and then you have to send for surgery with pure IVL, even though acute results are good. So that's why you reduce the volume by means of hysterectomy in nodules, then followed by shock it. Then you will get a very good result with the device energy, especially the calcific nodules, which is a safety approach.
But the nodules, hysterectomy, the problem is the wire bias, which tends to go away from the nodule.
No, Mova, please. Only a wire bias with rota, but not with orbital. I have seen, we did so many cases with orbitotripsy where without wire bias, because the working platform orbital is the wall, not on the lumen. So it will shave very effectively the nodule, then followed by tripsy with a very good lumen gain. I have a bulk experience. With pure IBL, I got a recurrence, very high recurrence within 4 months. I have sent surgery for almost 6 cases with pure IVL strategy. Even the acute results are good.
So you suggest first do
you have to do a stripsy. Hysterectomy followed by the wire bias is there, do rota. If you think wire bias is there, wire bias is not there, then you can do orbitotripsy. Very effective procedure I have seen in my view.
According to you, orbitotripsy is the best for the calcific nodules.
Yes, nodules.
Okay.
No, I agree with you. Like I also kind of love it in especially eccentric calcifications. And but what I disagree with the company who sells it actually is that it will replace aggressive post-dilatation. It's all about the hybrid approach or the combination of 2 devices. You have to utilize 2 devices. By the orbital, you basically, as you just said, you shave or debulk the calcium, but you have to go back and do more work afterwards.
Yeah. Thank you.
Apart this, sir, I have a comment.
Yeah, please.
I mean, orbitotripsy, as you just mentioned, probably
Yes.
I go with the view expressed by Dr. Matthias. So doing orbital is fine. Probably, doing additionally IVL, I mean, keeping the cost factor aside, which is aims the cost of OPN, but is it really doing the justice or worth the price actually? Because
Yes,
doing the
100%
same job, OPN
Yeah.
does a similar job post tripsy.
No, Dr. Ashok. Orbital only can do superficial calcium and subintimal calcium, but deep subadventitial only IVL, which will just break the stone into pebbles. Without IVL, only just hysterectomy in nodules usually won't work, because you have to shave the one which is protruding into lumen, and then you have to weaken the subadventitial calcium. You have to weaken the subadventitial calcium by means of IVL to have very good luminal, which is a safety approach, what I am telling, because orbital only by means of Mullin's effect, it will weaken the media, but not the calcium. That's all. So to make the stone into pebbles, subadventitial deep calcium, the only IVL will work. It is not the hysterectomy.
Supplementing orbital with OPN, that's the question I had, with a bigger size 3.5 balloon instead of orbital with the IVL.
No. Because my observation, the safety
Sorry
is
to
IVL.
Sorry to interrupt.
With NT.
𝐂𝐥𝐥𝐵 sir, could you please stop sharing the screen?
Okay.
Dr. Ashok, I think putting a OPN over a pebble will make it perforate. Instead of cracking with an IVL, if you just shave it and put an OPN over that, you'll perforate the artery.
Yes, safety approach. IVL is a safety. At 4 atmospheres, it will create 50 atmospheres of shock waves. Whereas OPN, if you go 30, 35, you will be just shaking, keeping a cover stent in the shelf, keeping ready to fight if anything happens. That's why. It is safety approach, what I want to convey.
But for a true nodule, I think there is no other option available also. Because true nodule, even IVL is also not safe. OPNNC, this is what my question was. The OPNNC, we can't go blindly and dilate. So the only option we have is rotate orbital atherectomy, shave it, then use IVL, crack it, and then you decide. Probably after that, you won't need anything further.
Thank you, Dr.
Perfect. Thank you. Thank you.
I mean, we still need to get that data from a proper trial, which indicates that you have to combine orbital atherectomy and IVL to adequately tackle those calcified nodules. I personally believe that it's an overkill because and we will prove that hopefully in the near future that by using OPN that you will address the calcium at least as effective as shockwaves. And especially, I'm deeply convinced that we've seen that in our data over and over again, that the OPN is a very powerful device to tackle deep calcium, especially more so if it's concentric.
Yeah, concentric.
Thank you.
Do we have Dr. Tejveer's presentation ready? And
yeah.
please
share my
share.
slide now.
Please share the screen and we can start. Over to you, Dr. Tejveer.
Yeah. Am I visible? My slides visible?
Yeah, visible. Audible.
Full screen.
Yes, sir. Perfectly visible. Yes, sir. Perfect.
Yeah, thank you, and sorry for the delay. We are already late. And my today's topic is OpenNC, safe and efficient, and ready almost in the every cell option for calcified lesion and other difficult lesion like ISR lesion. As we know, ISR is a very notorious lesion, and it's very difficult to dilate the ISR lesion. So we have few options like the first option is cutting balloon, but sometimes we do not have the appropriate size cutting balloon, so we have to go with OpenNC, and OpenNC I found it a very good alternative for these reasons. So I will show you some cases. This is a 65-year-old female. She had stenting done almost 5 years ago, and now she presented with unstable angina. And we can see a distal RCA stent crossing the cracks and going into the PLB. It is having ISR. So I started with the regular NC balloon and 1:1 with the high pressure, but this post crux ISR, this is very tight, and it was not giving away, and no one was there. So I was scared of the perforation also because the distal vessel is smaller because of the bifurcation. So I went ahead with the ISR 1:1 with high pressure up to 40, 44, and then you can see after putting the stent, I was able to put a 3.5 stent in PLV and a 4 stent in RCA and good results. So now this is sorry. This is another patient, 65-year-old male with ISR. The stenting was done in LED around 8 years ago, and so this is the result after 1:1 high pressure OPNNC used. And this is another LED ISR lesion, and after OPN, you can see I was able to achieve the good result, acceptable result. That is very important in ISR region because sometimes we have to crack the already stented stent because of sometimes it is undersized and the reason for ISR wise undersized stents. So OPN was also a good option. I found a good option in these cases. So this is ISR of proximal RHCA and PLV. So we can see the PLV region is very critical, very tight with distal around TB1 flow. So I went ahead with 2 wire. Nowadays I used to put another body wire to make it like cutting and high pressure OPN use. So I used OPN and with the body wire, so I was able to create a space. And in the PLV, the initial stent was 2.25, and with OPN, I was able to put 2.75 stent in this PLV, and I, I, I dropped the studs of the previous stent. And proximal RC also, I used OPN, and I was able to get good result. Sorry, I don't have in house so imaging. So that imaging would have been able to get that picture better, but we do not have in house imaging. And these are the cases usually done in the of us. This is another case with RC ISR. So we can see. So this is the end result of the previous. This is the end result of the previous ISR, proximal and mid part of RC ISR. So nothing is complete without the supporting data. We can see the various studies showing the safety of OpenNC, and we can see the complication is nearly negligible and with some hasty section. Yeah, there are some perforation also because when we use OPN 1:1 when pre-dilating, then when going to high pressure more than 35, especially more than 35, then we can end up with this rupture of the artery perforation. So we should be careful after 20. We should go slowly, and we should, if we are using 1:1, then we should not go very high. So take home message is ISR and calcified coronary stenosis challenging treatment, and failure rate is very high. Conventional non-compliant balloon will have a burning effect and inadequate lesion preparation. So balloon may rupture, may cause vessel perforation and dissection. As adequate lesion preparation with OPNNC to trusting RVP of 35 may lead to significant greater luminal gain and a high procedural success rate and with better clinical outcome. It is also minimize the risk of catastrophic coronary artery perforation. Thank you.
Thank you, Dr. 𝐂𝐨𝐥𝐥𝐨. Wonderful cases and very beautiful results. Did you use DCB or a stent in all those ISR cases? What was your choice?
My first choice is because these are all cases of mostly government panels. So we cannot use DCB because DCB is not approved in government panels first. And the second thing, still in clinical trials, I mean, still in guideline, stenting is indicated, and DCB is still not in clinical guidelines. So I used stent, thin stud stent, translamina stent, this VivoSAR. So one thing is we do not have guideline, and another thing is usually these patients are some panel patients, so we do not have this permission for this use in panel patients. Yeah, I use in cash patients. I prefer to go with DCB because putting another stent in ISR is not a good idea. DCB will have some better long-term outcome because of the stent-free.
So I think this was the last case. I'll open the house for panel discussion for any question answer.
I think Dr. Tej's very nice presentation regarding ISR.
Sorry
What
to
we
interrupt, 𝐂𝐥𝐥𝐵 sir, could you please stop sharing the screen?
Yeah.
especially Dr. Tejasvi, very nicely you presented. What we observation, especially calcific ISR, these two tools are very, very useful, especially IVL and OPN. So we have similar experience, especially underexpanded stent restenosis in calcific segments. IVL plays a significant role because we went with routine NC even up to 30 atmospheres, it did not yield. Then we did imaging, napkin ring of calcium. So we did IVL. Still, some indentation is there. Then we can able to do with OPN with this device energy. We got very good result. What I presented with post primary, the stent underexpanded stent with a very dense calcium, especially with dense calcium. Even after IVL, also we have seen the underexpansion still. So with that one, you shock it, make it pebbles, and then with and redistribute with OPM. So this is the strategy sometimes we apply, especially with the dense fibrocalcific ISRs. We observed with a very good optimal result and patency rates. And suppose if neointimal hyperplasia, OPN itself is sufficient. In case of dense calcium with fibrosis, yes, sometimes IVL only it may be sufficient, or IVL plus OPN with a very good result. Actually, with the image guided, we have done many cases.
Yes, I totally agree. Because IVL will put a crack in the calcium, then OPN it will help to gain the lumen. So, but only challenge in India is the cost factor.
Yes,
Because,
yes, agree.
yeah,
Yes.
that will add on the cost, because sometimes, many times, the patient are not in a position to pay this much.
So, PN sir, like as you mentioned, like you will be using preferably IVL and OPN. In case of intraintimal hyperplasia, when we have seen in the imaging, there is not much fibrosis or not much calcium. Would you consider using cutting balloon or scoring balloon, or would not consider those balloons?
Yes, definitely. I will consider more of cutting balloon, which is more effective tool than angiosculpt or scoring balloon. And then fibrous cutting or OPN, depending upon the affordability, because I think both are of it seems similar cost, OPN and the cutting balloon.
OPN cutting, OPN probably is cheaper, I believe. OPN
No,
is cheaper than cutting.
similar. No, no.
Similar.
Both are similar cost, 60,000, 65, 60,000, both.
Mechanism like neointimal hyperplasia, if we just suppress it or compress it by OPN and C versus if we cut it by cutting balloon, don't you think
Yes.
the cutting balloon would give an edge over the plain OPN and C?
No. Both are equally effective, because the peculiarity of OPN is cutting, it will produces only 3.1 millimeter to 0.2 millimeters cuts, then it will dilate those cuts. Whereas the OPN, even at 35, 40 atmospheres, it will increase further size. But the impact it was creating is almost, it will stretch the fibrous tissue in such a way, it will produce cracks and open it. In my experience, I have seen, we have done cutting balloon as well as the OPN balloon also with image guidance with a very good luminal gains. Safely, especially fibers, hyperplasia type of varieties.
I mean, if you have a lot of neoatherosclerosis with what the majority of us would say is soft plaque or stuff like that. There, I believe that you don't have to use modified balloons, but when you have mixed plaque with fibrotic as well as lipid-rich lesions within the stents or instant restenosis, I think the hybrid approach is very effective. But in the majority of cases, I believe that the OPN will do the job very nicely. And I mean, most of our health, and that's something which is probably similar to in Switzerland to India, is that we have cost restraints. And I think if you have to pick one device, I would still opt for the OPN because it will do the job in the majority of cases.
Thank you.
And I'm not sure if you have to spend, I don't know, there will be about, because the shockwave is extremely expensive in Switzerland. It's about 2,600 Swiss francs, which accounts for about 3,000 US dollars. And to use both, to combine 800, about 7 to 800 francs, I think is the OPN in Switzerland, again, like 900 US dollars, to spend more than $3,000 for lesion preparation. That's something which most patients can't afford.
Thank you.
I think OPN gives you cutting plus NC balloon, both rolled into one.
It doesn't cut, but it gives a sufficient pressure to kill everything around.
It cuts by stretching. That's what Dr. Kapardi is saying. But
Yes,
by
sir.
stretching, it cuts.
It at least causes severe tears, which help to open up the lumen.
Any other question?
Yeah, my opinion from the house is anybody using body wires with OPN just to put a cutting effect and then similarly to decrease the risk of perforation, vessel perforation? Because I am using now with NC also and with OPN also. I am getting a little better result with the body wire and lesser chances of perforation, vessel perforation. So any experience?
Actually, it's a good idea, but we did not implement. Actually, it's a good idea actually to have OPN with a body wire so that it will act as a both high pressure and scoring, like scored with the wire which was passed the body wire. It's a good idea actually. Thank you, Dr. Thank you.
And when the OPN balloon grips the wire, you can pull it out and leave the other wire for subsequent intervention.
Yeah. Another advantage is if sometimes the OPN gets stuck in the wire, then we can put out the assembly and another wire is in place. We do not have to rewire the vessel.
So thank you for giving innovative ideas also, Dr. Tejas and Dr. Mohan.
Thank you, sir. Thank you.
Mr. Hassan?
I think.
Yes, sir. Thank you very much, sir. Thank you, sir. In fact, it was a pleasure having all of you, sir. In fact, nothing could have been better to have and listen to a galaxy of a speaker today evening. I think this will go a long, long way to improve our understanding of OPNNC. One thing we really understood, I think, is the device synergy is the way. Is the way going forward, and because there will be always an unmet need, which will help us to treat patients better. I think OPNNC is definitely the Swiss knife, which helps you to achieve this. In fact, today, sir, just at the end of this, I only wanted to give you all of a message that said we at Translumina are committed to work with all of you and try and collaborate. And see that you get a pristine outcome when it comes to PCI. It is only because of the kind of technology which we have today, whether you want to image it, crack it, and or whether you want to coat it. So you have a complete combination of our assist high definition imaging system, which is today is one of the best in the world. followed with the for cracking, sir, you have OPN or IVL. Both the modalities are available. And to coat, you have a world-class drug-coated balloon like Protege. And when it also comes to stenting, we have both polymer-based and a polymer-free stent, which nowhere in the world, not many companies have achieved this. And when it comes to evaluation, we are coming very soon with the options wire. So what I'm trying to say, the long and the short, is that today we have the best of technology and the most advanced of the technology, which perhaps the ABC, also the company which is there, sir, I don't want to name it, but these companies also, most of them who consider to be the most advanced, they also do not sometimes perhaps offer the kind of technology today we are offering, sir. Hence we look forward to see that the benefit of it, this can be extended to more and more number of patients. And I really take this opportunity to thank the entire group of chairperson, Dr. Sharad Chandra sir, Dr. Aftab Khan sir, and Dr. Girish Navasundi sir, and the host of speakers who talked today, the sixth speaker, who really went on to speak a lot on OPNNC, and especially Dr. Matai Basad joining in from Switzerland. So thank you. And above all, I think Dr. Abhishek Tripathi sir, who really comprehended the program so well, and our great speaker, right from Dr. Pilen Kapardi sir, Dr. Ashok Kumar sir, basically all of you, sir, Dr. Devapriya Mondal sir, all of you, sir, really, Dr. Tejveer sir, you all added, Dr. Bhanja sir, you all added a lot of value to the entire program, sir. So we sign off as we go forward, and have a great weekend. And we look forward of all of you in various other platforms of a similar nature. So as we sign off, we really very thankful on behalf of Translumina today evening, sir.
Thank you.
Thank you.
Thank you so much, sir. Thank you.
Thank you.
Thank you very much for having me. It was a real pleasure for me, and I haven't enjoyed a webinar for such a long time. It was a really accomplished group which you brought this day together. I was felt really honored to be invited. Thank you very much.
Thank you.
I
Thank you,
really
Dr.
enjoyed
Miraz.
it.
Thank you.
Thank you.
Thank you.
Have a beautiful
Bye.
weekend.
Bye. Bye.
Enjoy. Thank you. Good night.
Good night.
Bye.